Bismillahirrahmanirrahim. Hello friends. Today we will discuss about the Varicella-zoster virus infection. Introductions. Varicella-zoster virus is an agent causing varicella or chickenpox, the common childhood infections. Following resolutions of the chickenpox, Varicella-zoster virus lie dormant in the spinal dorsal root ganglia until a decrease in cellular immunity triggered the reactivations of the virus, resulting in herpes zoster or shingles. Varicella-zoster virus is a double-stranded DNA virus belonging to the herpesviruses family. Chickenpox. Synonyms is varicella. Chickenpox is an acute contagious viral disease caused by Varicella-zoster virus. Mode of transmission is microorganism enter the respiratory system through airborne droplets or direct contact with infective lesions. Clinical features of the chickenpox are listed below. Age are mostly affected between 5 to 9 years old, but this is not the exact age which is the people who are affected. Sex, no sex predilections. Location, trunk, face, extremities. Sign and symptoms. It occurs commonly in the winters and spring months. We have skin lesions. In chickenpox, initially the lesions appear at unilateral sites and turn to vesicles in 1 to 2 days, sometimes coalescing to form bulla. The lesions then rupture and release their content, ulcerate and form crust over it. Is, is Scarring and hyperpigmentations or hypopigmentation at the lesion site may persist for a long period or may remain permanently. The lesions begin on the trunk and spread to the face and extremities. Pain will be constant, severe, burning, throbbing, or stabbing in nature. Pain duration is variable, but it occurs usually less than 1 month. Systematic symptoms such as headache, low-grade fever, malaise, fatigue, anorexia, corneal ulcers, and conjunctivitis are seen. Regional lymphadenopathies may be also seen in these symptoms of the chickenpox. There is a picture showing that there is a baby with the chickenpox and having a low-grade fevers, and the picture showing below the other picture is corneal ulcers and conjunctivitis are seen in the patients. Oral manifestations. The most site of the oral mucosa is affected is buccal mucosa, tongue, gingiva, palate, and mucosa of the pharynx. Mucosal lesion initially slightly raised vesicles with surrounded erythema is seen. Later it ruptures soon and forms an ulcer. Loss of taste in the anterior portion of the tongue is seen. There is a clinical picture showing the oral cavity, showing the soft palate plus uvula, and the soft palate there is a vesicles like lesions, and there is a raised lesions around this the erythema is formed. Histopathologies of chickenpox virus. Similar to herpes simplex virus, the Varicella-zoster virus causes acantholysis with the formation of numerous free floating Zang cells which exhibit nuclear migrations of chromatins and occasional multinucleations. The arrow pointed in the histological picture is Zang cells. Complications in children, chickenpox complicate Tourette syndrome, secondary skin infection, encephalitis, cerebral ataxia, pneumonia, GI disturbance like vomiting, diarrhea, and hematological events, thrombocytopenia, pancytopenia, hemolytic anemia, and sickle cell anemia. In adults, varicella pneumonitis, encephalitis, ataxia, headache, drowsiness, convulsions, or coma. The risk of the death is greater in adults. Adults cause of increased prevalence of encephalitis in pregnancy, congenital or neonatal chickenpox, abortion, or congenital defects may occur. In immunocompromised patients, high fever, hepatitis, pneumonitis, pancreatitis, GI obstruction, and encephalitis. Herpes-zoster, synonym shingles. Herpes-zoster is an acute infection, viral disease caused by Varicella-zoster virus after the reactivation of the herpes Varicella-zoster virus. Pathogenesis. In human, primary infection with Varicella-zoster virus occur when the virus comes into direct contact with the mucosa of the respiratory tract or conjunctiva. Later, it is distributed throughout the body via a mononuclear cell in the bloodstream. After primary infections, the virus migrate along the sensory nerve fibers to the stellate cells and dorsal root ganglia, where it becomes dormant. The dormant virus may reactivate due to decreased cellular immunity and result in herpes zoster. The triggering factors include trauma, tumor, local X-ray radiation, and immunosuppressive drug due to reactivations lead to the reactivations of Varicella-zoster virus. The main thing for the reactivation is immunocompromissions. If the immunities of the patients decrease, so the virus develops more. Herpes zoster result from the reactivations of Varicella-zoster virus in the trigeminal fifth cranial nerve. Any branch of the nerve may be affected, but the first divisions of trigeminal is commonly involved, which is ophthalmic divisions of the fifth cranial nerve. Varicella-zoster reactivation cause inflammation in dorsal root ganglion, accompanied by the hemorrhagic necrosis of the nerve cells, which results in neuronal loss and fibrosis. The incubation period is 1 to 2 weeks. Clinical features of the herpes Varicella-zoster virus. Age, which is most affected, is adult, because with age the immunity of the patients decrease. The incidence of herpes zoster increase with the age. Sex, no sex, predilections, location, trunk, face, extremities. Sign and symptoms are it's a group into 3 phases: prodrome, acute, chronic phase. Prodromal phase. Prodromal signs and symptoms develop 1 to 4 days before cutaneous or mucosal lesions. Pain, fever, malaise, headache, and migraine are commonly seen. Initial viral replications, ganglionitis, neuronal necrosis, and neuralgia. As the virus travels down the nerve, the pain intensify as burning, tickling, itching, boring, prickling, and knife-like in nature. The pain develop in the area of the epithelium and are rated by the affected sensory nerve. There may be The pain develop in the area of epithelium innervated by the affected sensory nerve. There may be reoccurrence in the absence of vesiculations of the skin and or mucosa. Acute phase. Clusters of the vesicles set on the erythematous base. Within the 3 to 4 days, the vesicle become pustular and ulcerate. Crust develop after 7 to 10 days. Lesion follow the pain of affected nerve and terminate at the end. Exanthema resolve within 2 to 3 weeks in healthy individual. On healing, scarring with hypopigmentation or hyperpigmentation is seen. The picture showing the distributions of the lesions affected by the branches affected the fifth cranial nerve and manifest as a particular side of the uh, branches of the trigeminal nerve. As shown in the picture number 1, the mandibular divisions of the trigeminal is affected. In picture 2, the ophthalmic division, and in picture 3, the maxillary branch of trigeminal nerve is affected. Zoster since herpes. Zoster without rash, severe pain of abrupt onset, hyperesthesia over specific dermatomes, fever, headache, myalgia, lymphadenopathies are seen. Oral manifestations. Oral lesions may occur with trigeminal involvement or movables or bound mucosa. Lesion extend to the midline in conjunctions with skin involvement or lying affected quadrant. Lesion manifest as 1 to 4 millimeter wide opaque vesicles that rupture to form a shallow ulcerations. Bone necrosis occur with loss of teeth in the area involved with herpes zoster. Because of cross anatomic relationship between nerve and blood vessels with neurovascular bundle, inflammatory process within the nerve has potential to extend adjacent vessels. Xanthic osteonecrosis secondary to damage of the blood vessels supplying the alveolar ridge and teeth, leading to the focal ischemic necrosis. Interval between appearance of the exanthema and osteonecrosis is 21 days. Ocular involvement are direct viral mediated epithelial damage, neuropathies, secondary vasculopathies, permanent blindness. Ramsay Hunt syndrome, it also known as herpes zoster oticus, geniculate neuralgia, herpes zoster auricularis. Ramsay Hunt syndrome is caused by Varicella-zoster reactivation involving the facial and auditory nerve. Vesicular eruption may manifest anywhere in the facial nerve distributions. Hearing impairment, nystagmus, hoarseness of sound, tinnitus, vertigo, and pain in the external auditory meatus and pinna of the air. Loss of taste sensation in the anterior two of third of the tongue. Facial paralysis may also occur. Chronic phase. 15% of the affected patient progress to the chronic phase. Pain post herpetic neuralgia that persists longer than 3 months after the initial presentations of acute rash. It affects patients older than 60 years of the age. Pain characteristics is burning, throbbing, aching, itching, or stabbing caused by the light stroke of the area or from contact with adjacent clothing. Histopathology. Similar to the herpes simplex infections, diagnostic cytologic smear, Zang test, viral culture, serological test, prognosis and predictive factors, antiviral drug administrations. The prognosis for younger and healthy patients is excellent. Elderly people significantly show increased risk of complications. Post-herpetic neuralgia, deafness, meningoencephalitis, cranial nerve palsy, pneumonitis. Thank you very much. Please subscribe.